Hi, my name is Steve Kleiboeker. I'm the Chief Scientific Officer for Eurofins Virocor and Eurofins U.S. Clinical Diagnostics. On behalf of Eurofins Virocor, I want to welcome you all to our webinar today. It's my pleasure to introduce our speaker, Dr. Gregor Bond. Dr. Bond is an associate professor in the Division of Nephrology and Dialysis within the Medical University of Vienna, and he's also a consultant in nephrology and intensive care in the same department. Dr. Bond has trained a number of graduate students, looks like 8 total to date, and he's involved in teaching activities. He's a coordinator for the organ failure and replacement and transplantation course, as well as a lecturer in the MD and PhD committee. Dr. Bond is also a prolific researcher in the area of tortinovirus, and today he's going to share with us his latest findings for tortinovirus-based immunological monitoring. If you have any questions for Dr. Bond, please put them in the chat during the webinar, and we will have a Q&A at the end of his presentation. Dr. Bond, I'd like to turn it over to you at this time.
Thank you, Steve, for the kind introduction. And hello, dear audience. Thank you for Eurofins having me here for Vienna. It's this evening. For the US, it's just about lunchtime. So I'm very happy to talk about this topic, which is very dear to me. I'm actually working with the Teno virus since 15 years. And yeah, I'm very fond of this topic. And I hope you too after this webinar. So the whole thing is centered around how can we improve immunologic monitoring. And as you all know, that's the holy grail, not only in transplantation, not only in solid organ transplantation, but in medicine in general. There's nothing like an immunometer or nothing really to monitor the immune system. And I will give you some data that TTV might be a new and potentially interesting option to do so. These are my conflicts of interest relevant to this talk today. And yeah, that's the main topic. What we need is an immunometer. What does that mean? We need something that measures the strength of the immune system. And this is not only important, as I mentioned, in solid organ transplantation, but everywhere where the immune system plays an important role, and that's basically everywhere in medicine. Let's start with solid organ transplantation. Here on the left side, when the immune system when the immunosuppression is too low and the immune system is too active, we end up with graft rejection in our transplants. On the other hand, when the immunosuppression is too high, so the immune system is too suppressed, we end up with a lot of infection and cancer. What about the other fields of medicine when it comes to autoimmune disease, for example? If immunosuppression is too low, we do not reach remission with our drugs. Or when it comes in the field of oncology, when it comes to immune modulators, we see no response if the immunosuppression is too high, if the immune system is too active. So what to do? First of all, let's have a couple of slides if such a tool already exists. The short answer is no, but the longer answer is there are some tests that try to mirror the immune function. One is called the T-spot assay. Basically, it measures interferon release in leukocytes. And on the other hand, we have the immunoassay, and it measures the ATP concentration in lymphocytes. So these tests are restricted to certain compartments of the immune system, leukocyte and lymphocytes on one hand. So it maybe doesn't mirror the whole immune system, but only parts. But having said that, for the immuno, there is a randomized control trial. It has some limitations, but still there's a randomized controlled trial. And this is very, very rare when it comes to biomarkers. It's very rare that we have an interventional trial based on this biomarker and look into patient meaningful outcomes. Colleagues here in Italy did this, and within this randomized controlled trial, they dosed immunosuppression according to the immunoassay and found in the active group less infections. There are some caveats in this study. There are 4 primary outcomes and no p-value spending. There may be slightly more acute rejections, and there are some concerns about blinding. Anyway, this is a very good start for a test. Is there something else as well? Yeah, there is. This is a group from Lars Pappe from Germany. It's a 3-center study in pediatric recipients of a kidney transplant patients. And they go one step further, I have to say. They have a more functional readout here. What they did is they measure CMV, adenovirus, and herpesvirus specific T cells. And according to these T cells, they guide immunosuppression in the active group. The standard group is just standard of care. And then they looked in graft outcome 24 months later. And interestingly, what they found is in the active group, there's less graft rejection. So this is also a very nice first step, but only a first step because 49% acute rejection in a pediatric cohort in a control group is not what you should normally achieve, I would say. And I would say it is difficult to standardize such a test. It is a linear molecular lab, very highly skilled. This test takes 3 to 4 hours. You work with cell cultures. It's difficult to standardize, I would say, difficult for general worldwide rollout, but still it's a very nice start. And I like the work from Lars Pappe's group. So I want to present you something different, something more, I would say, and that's the TTV virus. The most interesting thing is that we have learned that the TT virus is not only controlled by lymphocytes, by T cells, but it mirrors more or less all the immune compartment. So it's maybe, it gives you maybe a broader picture about the immune function. We're not only looking on T cells here. But let me give you some details because I think most of you are not familiar with the TT virus. That's nothing unusual because we just learned about this virus 20 years ago. It's part of the annellovirus family. It's an alpha-talk virus. There are about 22 species in humans, and it's very highly prevalent, at least 90% in healthy adults. If you look very specifically with more sensitive methods, you find almost in every adult this virus, this infection. The route of infection is any, as you can imagine. It's highly contagious. The replication is everywhere, but it loves lymphocytes, mostly lymphocytes and hepatocytes. And most interestingly, it causes no disease. Researchers have tried to link it to any disease in the last 20 years, but were not successful. So no good hint that it causes any troublesome infection. And as I mentioned before, we at the moment believe that almost all the major immune compartments are involved in controlling this virus. So it gives you a broad picture of your immune function. It's resistant to conventional antiviral therapy. That's also important when we go into clinic. And the most important thing, and that makes it interesting, it's associated with the immune function. I will show you lots of data on that. And we have not only data in transplantation, we have only data from autoimmune disease, from infectious disease, from oncology. And it's not only our lab, but more and more data come up now, more and more data from different labs support this hypothesis that the level of TTV in the peripheral blood mirrors the immune function of its host. Let me show you a slide from Steve Lamic's group from Stanford. And I think this is very impressive. What they did, they really started the whole story. They kicked the whole topic with TTV. And they looked into mixed transplantation. I think it was heart, lung, liver, and kidney, and looked at the whole virome in general. What they found is that here on the very left, when immunosuppression is just introduced at day 0 of transplant, TTV is not really active. But if we start immunosuppression here, TTV and annelloviruses become the dominant group of viruses within our virome. So I think this picture is quite impressive what immunosuppression does to annelloviruses in our body. They explode. And based on this study and others, we and others formed the following hypothesis that we can use TTV load to monitor immunosuppression. So the whole idea is if TTV load is very low in the peripheral blood, your immunosuppression is also quite low. Your immune system is strong. This is maybe maybe you're at risk for rejection then. And the other way around here, if TTV virus is really high, there's a lot of immunosuppression, and the patient is prone to infection. There's maybe the golden middle. That's basically the hypothesis behind the whole story. Now, some words on how we measure TTV. That's quite important. And at the end of my talk, I will give you a bit more insights on what kind of PCRs are there in the market and what are the differences. And it's very, very important because as clinicians, we always want some cutoffs with viruses. And cutoffs really depend where you measure your TTV with what kind of PCR. So basically, the work of Fabrizio Maggi in Italy started the whole thing. He published primers on how to measure TTV easily in the peripheral blood. And when in the following talk, I will always refer, if I talk about this PCR as Maggi PCR or as in-house PCR. And basically, I think TTV Watch, which is now available in the US since this summer, uses this primers as well. So this is quite comparable here. One caveat here, if you read papers about TTV and you go in detail to the materials and methods, some people call it TT virus PCR or Anellus virus PCR, but it's other primers. They find other types of anelloviruses, more than TTV, less than TTV. So be careful when you read on papers that claim that they measure TTV. Also, some groups use altered primers of the original Maggi PCR. So this also gives you different results. What kind of material do you need? You can measure TTV almost everywhere. But normally you would send in plasma or serum. Normally it's about 200 microliters. It's also possible in less, so even in nasal swabs or in urine. So this is all the in-house PCR. This is a PCR you can also easily set up in your department. And then there is a commercially available a PCR. It's only available in Europe at the time being. Since 2022, it's E-certified and it's called TTV R-Gene. So I always differentiate in my talk between the commercial PCR and the in-house PCR. This is important because it gives you different cutoff values. It uses different primers, of course. If you want to have a bit of an overview about the data out there in solid organ transplantation, and I will talk about other fields in medicine as well after all, at the end of the talk, there's a narrative review by our group in transplantation in 2022, and we will come up with an update in Transplant International this year. To sum it up, one caveat, it's only single center studies so far, it's non-interventional studies, and there are some design limitations. We're still waiting for an interventional study. I will come to this also at the end of my talk. Most data available in kidney, a lot also in lung, and a little bit in liver and heart transplantation. TTV in all or most of the published studies is associated on one hand with rejection, on the other hand with infection. There are about 40 papers out there at the moment. It is associated with all kinds of rejection. It's not restricted to a subgroup. So it's ABMR, TCMR, borderline, subclinical, and so on. We have data in adults and the pediatric cohort. And the same accounts for infection. It's associated with overall infections, just opportunistic, severe, non-severe, you name it, it's associated. So this association is quite robust. I will deep dive a little bit in one of the studies from our center. The idea is that you don't, it's not necessary to believe everything I say. I will show you also some first-hand primary data here. So this is a prospective study, single center from our center in Vienna. We followed roughly 400 patients for a couple of years and did TTV testing by in-house PCR, by using the Maggi primers. Our primary outcome was biopsy-proven rejection. We also looked at treated infection. So what did we do? We measured TTV at certain predefined time points, and then we looked within this time point, between two measurements, was there a rejection or not? Was there an infection or not. And then we associated the TTV value before the event with the event itself and made associations here. And what we found was quite interesting. We found a strong and robust association between infection and TTV loads. For overall infection, this is this odds ratio, and then also the highest values or the highest odds ratios actually were calculated for polyoma virus associated problems or CMV associated problems. But the nice thing here is we had the TTV measurement 27 days, so almost a month before the infection happens. So it's predictive for infections. This gives us maybe some time to change the immunosuppression and maybe reduce the risk for infection. The idea is to measure TTV. If it's too high or too low, we will maybe react. And then the idea is to reduce the risk for infection. It's the other way around for rejection. Here the odds ratio is negative. And again, TTV was associated with rejection already 14 days before the event. So this also gives us some time for intervention. What about cutoff values? I always get this question, and it's always difficult with cutoff values. You know this from your everyday clinical practice. This is true for every biomarker. There is not the one and single golden cutoff value for no biomarker. Let's take C-reactive protein. We all use it in everyday life, but when do you have really an infection? At what level of CRP? There's not the golden cutoff, and it's the same with TTV. When it comes to rejection, the lower you go, the higher, of course, the risk for rejection. And I would say that taking the in-house PCR, that's below 6 log levels, the risk really starts going on. And it's the other way around when we look into infection. If you go higher than 8 log levels here, the risk for infection really starts. So if you are between maybe 6 and 8 log levels with the in-house PCR, then that's what I would call the safe zone. One thing that comes up quite recently, or came up quite recently, so this is unpublished data. Please be sensitive with this data. We haven't published it yet. And we associated here TTV with malignoma post-transplant. And what we did is we followed more than 400 consecutive transplanted patients and looked at the overall TTV levels in the first year. And then we associated this with malignoma in the 4 years to come. So we calculated the time-weighted area under the curve and associated with the malignoma in the 4 years after that. We adjusted this for all the major confounders that might be interesting for a tumor and TTV, and still have a quite reasonable p-value for this hazard ratio. So the higher the average TTV in your first year is, the higher is your malignoma risk. And here we also propose a cutoff value, which is quite close to the cutoff value you have for infection. So the risk starts here again above 8 log levels TTV in the peripheral blood. Another thing that's really important when you use TTV in the clinic is, when do I measure TTV? How long does it take to react? When does it react? And which tacrolimus changes? So these are all important questions. And we tried to answer some of them for you to use TTV in the clinic. What we did in this study was we looked at patients that had isolated tacrolimus changes. Nothing happened 3 months before, nothing else, and nothing happened 3 months later. So only an isolated change in tacrolimus level. And what we see here, white is the tacrolimus through level, and as expected, of course, at day 30, if we lower our tacrolimus milligram per day, we have a lower tacrolimus level. We would find, of course, this effect also on the next day. But of course, we see it here at day 30 and on day 60. But interestingly, TTV doesn't go down in the first 30 days. It needs some time. It needs at least 60 days. Unfortunately, we had not enough data points here on day 90, but my clinical feeling is we use TTV now for, I think, for 7 years in the clinical routine, and my clinical feeling is that sometimes it takes up to 3 months. The TTV follows your tacrolimus change. And it's the other way around. If you go up with the tacrolimus dose, here the full effect of TTV is seen only 2 months after the tacrolimus change. we have also some data from mycophenolic stop studies. These were studies our center and colleagues from Berlin tried to stop MMF to increase the chance for response to SARS-CoV-2 vaccination. And as a little side project, we looked at TTV, and what we found is if you stop MMF for 6 to 8 months, then you see an effect in TTV. So I think we have to wait for 2 to 3 months. So my idea is measure TTV every 3 months. Anyway, that's the time where you may want to see your patient in the outpatient clinic. It's roughly comparable to the HbA1c in diabetes. This also reflects what is happening with the immune system or with the blood sugar in the last 3 months. And TTV tells you what happened to the immune system in the last 3 months. And one point I want to mention, you have to do at least the tacrolimus change of 20% of total dose. But anyway, that's what you do as a minimum change in the clinic. So that's nothing you have to worry about. What about belatacept? Until recently, I thought you cannot use TTV in belatacept patients because one of my very early studies, cross-sectional studies, found sky-high levels on belatacept, and I thought, well, you cannot use that. But now we have some nicely done studies from Grenoble and Leiden, where they switched from tacrolimus to belatacept, so they had a direct comparison, and TTV was completely stable in these patients. So I think the cutoff values apply also in patients on belatacept. They do not apply to patients on mTOR inhibitors. At least we do not have the data right now. So I would be careful to use TTV on patients on mTOR inhibitors. And there are 2 caveats where I think you have to be careful to interpret TTV. When your patient is very lipopenic, then you cannot use it. This is unpublished data from our lab as well. And when you have very high CMV levels, you cannot use TTV. These 2 viruses somehow interact. We don't understand at the moment completely the interaction, but we're working on a publication to maybe solve this riddle. But at the moment, be careful when the patient is really lipopenic or has very high CMV counts. There you shouldn't rely on TTV. Now I have some case reports for you because I think it's a bit more, it's easily to grasp or more easy to grasp when you see actual real life data. So this is a young male patient, 23 years old. He got a transplant from one of his parents. I can't remember, mother or daddy. Anyway, he was lucky enough to have a live donor. And the first year went quite well. And then something happened. But if we look at the, let's start with the tacrolimus through levels. These are here in black. The tacrolimus through levels are always in range, always roughly about 7. This is what Symphony study told us to do. That's what we did in this patient. And at least in our center, we have a high rate of non-adherence. My colleague Frederick Hauptenthal is just at the moment publishes a study. So we see a lot of non-adherence, but we don't see this non-adherence when we look at the tacrolimus level. Our patients are very clever. They take the tacrolimus drugs 2 or 3 days before they have an inpatient visit. So we always have the tacrolimus level, but we know that a third or maybe more of these patients are non-compliant. So what to do? And now retrospectively, in these patients, we looked at the TTV levels. So here everything was fine. In this gray bar, that's the optimal range where we want to have TTV. Everything was fine there. But here, TTV dropped. As you can see, the tacrolimus level was fine, but TTV was super low. In this range, you would expect somebody who takes no immunosuppression at all. The creatinine was fine for some time, but then we met him with a creatinine of 12 milligram per deciliter with severe mixed rejection, and we couldn't save the kidney. And then I talked to him and said, well, have you been compliant? And he said, no, I always took my drugs and no trouble with that. And then I had a talk to him, just the two of us, without the parents. And I said, well, look, I have this virus, and this gives us some hint that you haven't taken your immunosuppression. Are you sure? And then he started crying. It was really heart bursting for me. And started crying and said, well, yeah, I didn't do this. And it was the kidney of my parents. Sad story. But bottom line is that we would have a lot of time to intervene. We saw if we would see the problem here, we can send him to clinical psychologist or psychotherapy, counseling, and help this patient here get more adherent. That's maybe the power of TTV. That's another case report, 67-year-old male patient. He had a living donation as well, ABO incompatible. Again, TTV, again, the tacrolimus was here around 7. But if you look at TTV, it was above the optimal range. And this patient presented once a year with a severe pneumonia. And then in the 4th year with life-threatening pneumonia due to pneumocystis. And then we reduced his tacrolimus level, and retrospectively we looked at TTV and saw, wow, these levels were super high. And then after we dropped the tacrolimus goal, TTV dropped as well. So TTV might or could have helped us earlier to risk, despite his ABO incompatible transplantation, to go lower with the tacrolimus dose, and we maybe would be able to save him from this life-threatening pneumonia. So far, so good. These are all data. These are all single-center studies. These are all association studies. These centers, or these studies, doesn't really, or they do not really prove that by using TTV we can really help our patients. We need some causal data. We need an interventional study. And as you know, these interventional studies, when it comes to biomarker in transplantation, they're super, super low. I showed you 2 studies. When it comes to rejection, I know of the Outsmart study in England. I know of the study from Stefan Schaub of urinary chemokines, but that's, to my knowledge, more or less, that's it. So we wanted to go one step further and prove that by using TTV and guiding immunosuppression using TTV, we can really improve or reduce infection and graft rejection. So we set up a multi-center study in Europe. You see here all the countries involved here on the left, about 300 kidney transplant patients from 13 sites within these EU countries. And what we did is that the active group was TTV guided, and the control group was normal guided, so as we do it in everyday clinical practice. So this was a blinded approach and a randomized control setting. And we had our last patient, we will have our last patient last visit in May, and hopefully have the results in 25. But I want to show you in more detail what we did in the active group. So in the active group, every 6 weeks, we measure TTV. And if TTV is above the optimal limit, we go with our tacrolimus target one step down, because we think this patient is over-immunosuppressed. We go one step down. If TTV is in the optimal limit, we are happy, we do nothing. Tacrolimus target stays as it is. And if the TTV level is below the optimal limit, we fear that this patient is under-immunosuppressed, and we go one level up with the tacrolimus target. So it's more or less a personalized immunosuppression based on TTV. And hopefully this study will clarify the value of TTV. You can have a look at the protocol. It's published in Trials, and we will publish the analysis protocol, statistical analysis plan this year as well. So that's it from transplantation. At the final slide, I will also show you the cutoff values for lung transplantation. They have been defined as well, not so far from for heart and liver, but my guess is that they're very close to the kidney cutoff values. But let's move to different fields of transplantation. TTV is not only interesting for solid organ transplantation, but more or less in a broad, or not in all, but in a broad field of medicine. Let's start with adherence. This is a study from our center. We used here a very detailed measure of adherence. We used questionnaires, electronic drug monitoring, pharmacy refill records, and so on. Everything you can get. Based on the basis, we defined adherence or non-adherence. And then we looked at TTV levels. And interestingly, patients who were at multiple occasions non-adherence had lower TTV levels. So these are the patients maybe who are under immunosuppressed. It's not published so far, but I think it points to the direction that TTV can maybe also used in a multi-tool approach to filter out patients that are under immunosuppressed. Another thing that is interested when it comes to vaccination, I know the pandemic is over and the interest in SARS-CoV-2 vaccination gets lower and lower, but vaccination in immunosuppressed patients is in general a very important topic. The more and more powerful vaccinations, the RSV virus, and so on, varicella, you name it. And our immunosuppressed patients have trouble to get serological or cellular responses. So we looked into, this is based on the German multicenter studies, and we measured TTV with the in-house assay. And what we found is in patients with high TTV levels, so TTV loads above 6 log levels, so these patients are quite strong immunosuppressed. They have no chance of getting a decent serological response, no cellular response at all. This is in that point interesting because we had two studies I can think of, two studies, one from Berlin, one from our center, where the investigators paused MMF for a couple of weeks, then did the SARS-CoV-2 vaccination. The idea was to increase the response on SARS-CoV-2 vaccination. So I think the study in Berlin was positive, ours was negative, so not very convincing. So maybe TTV can help on an individualized level. So patients with very high TTV levels, maybe these are the patients where you can risk to pause or to reduce MMF or to reduce TTV for a couple of, reduce the tacrolimus for a couple of weeks. Then you do your vaccination, wait for a couple of weeks for a serological response, and then you go up again. Of course, this has to be tested in a randomized controlled trial. We don't want to set our patients on risk for acute rejection, but that's maybe a nice idea for a vaccination design trial. This is data from patients with rheumatoid arthritis. And we tested a couple of the DMARDs here in our patient, and you can see in almost all of the DMARDs tested, TTV goes up here in green. And the interesting thing, TTV load was associated with response with the S-dye and the C-dye. Patients with high TTV levels, where the immunosuppression is very high, they have the better response. And this is now tested also in a new funded project at our center, in the SQUEEZE project. There will be a randomized control trial as well. So hopefully we have some more data in rheumatoid arthritis on TTV. Another interesting study from our colleagues in Paris, they looked at TTV levels at the time of presentation of patients at the emergency department. And then they measured TTV load, and then they looked what happened to these patients and which of these patients were admitted to the ICU because of their SARS-CoV-2 infection. These are the patients at risk. You don't want to send these patients home from your emergency room. So what they found is that TTV above a certain level, this was an independent risk factor for administration to the ICU. Even if you put obesity, age, sex, and all the other important risk factors for SARS-CoV-2 or COVID disease in this in this model. So maybe a nice triage test you can use in the emergency room when it comes to infection risk. Another interesting thing is where TTV might be interesting is CAR T-cell therapy. As you know, CAR T-cell therapy is nothing that is only used in oncologic disease, but it will spread to autoimmune disease and other indications. So researchers in Valencia found here an association between TTV load and progression-free survival on one hand, and on the other hand with side effects of CAR T-cells effects. That's immune effector cell associated neurotoxicity syndrome. It's hard to spell if you're not in this field, but you will see it sooner or later because CAR T-cell therapy will spread and so will ICANS. So if you have something that can predict over or under immunosuppression using CAR T-cells, that's maybe also an interesting approach. I think that's one of my last slides here when it comes to TTV applications. What about cancer? I showed you data that TTV is associated with cancer and transplant patients, but these were patients where ovarian cancer was diagnosed for the first time. And at the day of presentation at our clinic, TTV was measured. And as you can see here, survival probability was much better in patients with low TTV counts, where the immune system is stronger, compared to patients with low TTV counts, where immune system is more immunosuppressed. And most interestingly, TTV was still associated with progression-free survival when you put the FIGO state, the age, and complete resection in this model. So strong predictors for progression-free survival. TTV was still significant in this multivariate model. So last but not least, I want to speak about the maybe for clinicians boring part, but it's really, really an important part. It's important that you know your PCR. When you measure TTV, it does matter where you measure it and with what kind of PCR. Let me give you one example. If you do the in-house PCR at Fabrizio's lab in Rome, or if you do the in-house PCR at our lab in Vienna, you have one log level difference. That doesn't mean that one of us is doing it wrong. We have a different extraction methods and so on and so on. We have a linear and stable difference of one log level, but that's very important to know where the performance of your PCR is. So if you're here, you have to know what's your difference to our published data, what's your difference to the data published by Fabrizio Maggi and others, because if you look at published cutoff values and you don't know how your PCR you're using is performing, you cannot apply these cutoff values to your patients. And the other message is TTV PCR is not TTV PCR. There are also differences when it comes to primers, of course. So here we compared our in-house PCR with the commercially available PCR from TTV Argene. And we found that the difference is 1.4 log level. So our in-house PCR is 1.4 log level higher. So we have to recalculate the cutoff values when we use other PCRs. This data is published, the 1.4 log steps, but to make the story even more complicated, it does seem that the association is not truly linear, as we expected here, but it's maybe a quadratic function, because if we go higher and higher with our TTV loads, we see that the difference gets higher and higher. So at the moment, a colleague of mine is analyzing this data, and we'll publish it this year. And then we put up an online tool, and then you can easily calculate one PCR to the other, no matter how high your PCR is. One last thing. Even if you use a highly standardized approach, these are data from our Horizon EU multicenter study. Here we have the values from 13 labs, and these labs were highly trained on TTV Argene to follow one specific protocol and to do the PCR properly. And as you can see, the intra-laboratory standard deviation is very low. but still it's a manual PCR and there are differences. So if you do your PCR here in the pink center, here in the light blue, you end up with a difference between a half and 1 log level. So it does matter where you do your PCR, even if you do it highly standardized. So this brings me to my last slide already. And this slide is maybe the most important if you are a clinician and if you want to use TTV in your everyday clinical practice, because here comes the highly desired cutoff values. So if you look at a kidney transplant patient, I would say that the risk of infection starts between 7 and 8 log levels. And the risk is really high if you go above 9 log levels. Please keep in mind that these levels are based on the MAGI PCR of the Vienna in-house PCR. That's the same you can send in the US to Viacor Eurofins. And yeah, just to mention, 7 and 8 log levels here, the risk starts for infection and malignoma. On the other hand, the risk for infection starts if you go lower than 6 log levels. I haven't shown you the data, but in long-term transplant, if you go above year 4, 5, and so on, maybe you can go as low as 5 log levels and you have no risk. For lung transplantation, you have to stay higher with your TTV. These are data published by Peter Jaksch. I haven't shown you the original data, but he came up with a lower cutoff of 7 log levels. So, of course, lung transplants need more immunosuppression. And then trouble really starts if you see a patient with a 4 standing before your log level. This is highly likely a patient that is non-adherent. This is a patient you have to talk to, you have to send to your clinical psychologist, or to start behavioral therapy, change his immunosuppression intake pattern. If you want to be sure that your vaccination works, maybe you want to go a little bit lower with your immunosuppression, and the vaccination works if the patient is below 6 log levels. Having said that, this is also the risk in year 1, so I wouldn't suggest to do this in year 1. But on your long-term transplant patients, where the risk starts at 5 log levels, there maybe you can risk to go a little bit lower than 6 for a couple of weeks. Please be aware that this hasn't been tested in a randomized control trial. There are some caveats where you cannot use TTV, and this is also quite important to keep in mind when you want to use TTV in your everyday clinical practice. You cannot use it in the first 3 months. If you maybe have still in mind the slide from Steve Quake's group in Stanford, where TTV is all yellow, so it starts with 0 on day 1, so not really 0, but on a very low level, and then goes up in the first 3 months. It goes up and up and up. So it doesn't represent your immunosuppression the first 3 months. The peak is at 3 months, but your immunosuppression is basically the highest in the first 3 months. But their TTV is still following your immunosuppression. As if you can remember, it takes 2 to 3 months to reflect immunosuppression. So please only start using it in month 4 post-transplant. And these cutoff values I've given you here, we have quite convincing data for the first year of transplant, so between month 4 and 12. I'm quite convinced that the risk for infection myeloma stays the same after 1 year. My colleague Sebastian is working on this data at the moment, but for the risk of rejection, you can maybe go a little lower, but these data are pending. You cannot use it in patients with mTOR-based immunosuppression. And then be careful with so-called never raises. What are these patients? We have seen a couple of patients where TTV never really goes up. Those patients never show a peak. That's why it's important to measure TTV serially in your patients, because it's important to know, is this a patient who has a proper peak? Does he ever go above 6 log levels or not? Because if he's always on a very, very low level, then these are the patients where TTV is not resembling immunosuppression. We don't know why at the moment, but it's like that. If you cannot use it in severe leukopenia, let's say roughly below 1 giga per liter, and you cannot use it if CMV is about higher than 4 log levels. You have to do a tacrolimus change of about 20% more or less milligram per day to see an effect in TTV. And this effect takes about 2 to 3 months to see the full effect. So best thing is measure TTV, react on this TTV with your tacrolimus goal, and then control for it 3 months later. And one thing that is important to keep in mind, please know your PCR, know what your PCR is telling you, what are the cutoff values of your specific PCR you use. Don't go only in papers and use the cutoff values published in some papers. You have to be aware if this is true for your PCR. And the best thing would be evaluate the PCR in your own cohort. Of course, this is a lot of work. So at the end of my talk, this is the great team I'm working with. This is us running in Boston. I think this was the ATC 2 or 3 years ago. This is one of our summer parties here. If you want to have further information on TTV, please visit our webpage. We published a lot of, if you go to the results section, there are about 30 or 40 papers on TTV free to download for you. And then I want to make some advertisement for the ESOT Congress. I'm in the scientific committee of the Congress. Maybe I can lure you into a travel to London. It's London in the summer. I can guarantee it's a nice experience. It's a long travel, but I guess it's worth it. See you hopefully in summer in London. Yeah, and now I'm happy to take your questions.
Yeah, thank you, Dr. Bond. That was really an amazing talk, and appreciate all the latest updated knowledge that you provided. We have quite a few questions that came in during your talk. We'll try to get to several of them within the time we have. Let's just start with one general question. Do you think that most of the data you presented was, I believe, in kidney? You did mention specifically some differences in the lung, but what about the other solid organ recipients, such as liver or heart, for example? Do you think TTV will have equal value there, or do you anticipate having to have some additional research that provides cutoffs similar to what you mentioned with lung?
That's a very important question because, yeah, kidney is only one part of solid organ transplantation. As you mentioned, of course, that's right. We have quite solid data on lung transplantation, and I haven't mentioned that, but Peter Jaksch from our lung transplant group, he has an intervention trial as well up and running. It's a 2-center study with Hannover, and they closed the study already. It's quite similar to my study. I almost copy pasted his protocol, so it's quite the same as my protocol. We will have this data, I hope, also late this year. So he tested. It's an interventional trial as well, using the cutoffs I provided. So I think we'll know for sure by the end of this year. But my guess is in lung transplantation, it's one log level higher when you look at rejection. It's the same when you look at infection. This makes sense because I think in all our immunosuppressed patients, the risk for infection is the same depending on the level of immunosuppression. So I think it will be the same. Without having the data, I will postulate that it will be the same for liver and heart. It's quite logic that it will be the same, but it might be different. The cutoffs might be different when we look into rejection. So my guess is, we don't have the data, that we can be a bit more relaxed when it comes to liver. We know liver needs a little bit less immunosuppression than kidney. Some of the patients are on tacrolimus or mTOR or mono after a couple of time. And heart is quite similar to kidney, I guess. So there will be some data, hopefully this or next year by our heart transplant group. And our liver group is also working on data there. So hopefully this or next year, I can give you a definite answer.
Excellent. Okay, thank you. And maybe just taking the same thought process and applying it to pediatric patients, do you believe the same? And I know there's been studies, but do you believe the same trends will apply to the pediatric patients?
Yeah, so again, we don't have enough data there, but there are a couple of data now that show that there's a very robust association between infection and TTV in the pediatric cohort. We don't have the data for a rejection because luckily enough, it's a very rare event in the pediatric cohort. And even in our department where we have a lot of transplant, we haven't been able to come up with a reasonable event number. So I cannot tell for the moment. It looks like so the association is true for infection, but the cutoff level hasn't been defined so far. So my guess it's quite similar for the pediatric cohort, but we don't have the data yet.
Okay, excellent. So you use the term melanoma. By that, are you meaning all malignancies in general when you're looking at the long-term complications?
Yes, important question. Yeah. So we have excluded some of the, so I think some of the in situ dermatology, I think basalioma and the low malignant ones. So some carcinoma in situ. I think we have excluded carcinoma in situ in colon biopsies, something like that. But otherwise, it's the vast majority of malignoma. Of course, when you look at the transplant cohort, most of it is lymphoma, melanoma, things like that. But we have also solid organ cancer as well. So it's more or less all the cancer, yeah.
Okay. And then we've had a couple
We have
questions.
we have the data on ovarian cancer. This is a non-transplant cohort, but there is a completely different cohort. But there we see a strong association between ovarian cancer and TTV load.
Yeah. Okay. Had a couple questions, just maybe to reiterate the frequency of testing. I think you mentioned 2 to 3 months after a change to tacrolimus, but what's kind of an ideal frequency of testing of TTV in the first year, and then I'm assuming that might change in subsequent years post-transplant?
So in Vienna we are quite lucky that we see all our patients really in an in-house center. So we follow up all our patients exactly where they have been transplanted. Of course, that's not usual. Patient travel for their transplant and then have their outpatient visit somewhere else. So it's easier for us to in our center we have the TTV measurements quite often. But I think at least you should do them every 3 months. So it makes sense to start to have at least a peak value, to have a value before you at the day of transplant maybe, and then at least in month 3 or 4, because we want to know, is this a never riser or not? Does TTV work? So we'll do maybe months 2, 3, 4, maybe 2 or 3 measurements there, and then I would do every 2 or 3 months. I guess that's enough. Every 2 or 3 months, and that's basically where you will see your patients. I mean, that's reality, and then later on, maybe you have only the chance to see them once a year.
And you mentioned the never risers. What frequency do you see patients that don't have any CT value or so no TTV detected, and how do you interpret those?
Yeah, so no CT value at all is very rare. So it's maybe only 1 in 100. But
Okay.
never raisers, it depends really how you define them. Even we define them differently. We try to keep the definition now stable as we have more and more data. But if you, it's maybe 5%, something like that. It's about
Okay.
5%, where we are not sure if TTV works. My guess is, I mean, we are all TTV infected. So maybe my guess is that with our primers, maybe we don't get all the TTV. Maybe with a different set of primers, we see different CT values. Maybe with other techniques, maybe if we do combine single strain PCRs, but these are expensive, of course. Yeah, I'm not quite sure. Maybe these are infection with only one strain of TTV, and if you have higher levels, these are infection with 5 or 10 strains. Anyway, within our TTV guided study, we will go into exactly this question. we will deep analyze these patients and do single strain analysis and maybe shed more light in this question.
Excellent. Okay, that'll be really interesting to see the results of that. In thinking of the TTV guided study, do you plan on following those patients long term for some of the complications? Again, the malignancies, but also I'm thinking kidney graft loss, kidney loss, just due to immunosuppression, long-term immunosuppression. Do you have plans to follow them longer term?
Yes, we'll do that. It's difficult to do so because the funding ends, but
Yeah, yeah.
I have really all of my colleagues here on board. This is an investigator-driven study, so the investigators are really fond of this whole idea, and so we'll do that, even with very limited funding. So we will follow them up for 10 years in total, and we look into patient survival, graft survival, once a year, EGFR, so we'll have long-term data. I think we won't be able to manage to get data on malignancy and data on infection. This would be too granular and too difficult to get, but at least we get death due to malignancy. So there will be some data on long-term malignancy, yeah.
Yeah, okay. And then given the variability between the various PCR tests that are out there, would this field be benefited by having some international standard that perhaps could bring the tests more closely into alignment? Those have worked reasonably well with CMV and BK. They're not perfect, but they do bring things in closer. What are your thoughts on that?
Definitely, that's the way how we have to go on. I mean, when I entered this field, I was really naive. I thought, well, CMV is CMV, no matter where you measure it. But then I learned, well, it's about 2-3 log levels difference, even if you stick to WHO standards. And now it gets more and more standardized, as you mentioned. This is a process that already started, at least for Europe, with QCMD. So QCMD is a non-profit organization. I guess you're familiar with that. I think for the moment they're operating only in Europe, but I'm pretty sure you have instruments in the US as well. So you can send, so they will distribute linearity panels or external quality control to your PCR, and then your centers will be able to standardize the PCR. I think that's crucial because if we rely on cutoffs, it's crucial to have standardization.
Yeah, and the cutoffs is, I think, another question that came through. Would the change in value over, say, the 3-month frequency of monitoring, for example, would the change of value perhaps help reduce the dependency on single cutoffs, or do you think staying with single cutoffs is going to be the most useful in the field?
That's a very good question, but it's very difficult to tackle this question scientifically. What I do in everyday clinical practice is I look at a picture TTV, everything I measured in the last years, and then I have my tacrolimus levels, my prescribed milligrams, and so on. And then I look, well, what happens in the last year? How is TTV reacting on my immunosuppression? And then I got somehow a gut feeling where I should put my patient. But to put this dynamic into a calculation or into a scientific paper is very difficult. As you know, clinicians hate calculations.
Mm-hmm.
They want one cutoff. And of course, a dynamic process or a dynamics would give us much more information. It's something I haven't given up on working on. So let's see.
Interesting. Okay.
Yeah.
Well, I think we're at the top of the hour. We have a lot of questions still pending. I've been reading through them. I think a lot of them we can follow up with after the webinar. But I just want to thank you, Dr. Bond. That was an amazing webinar, amazing seminar, great Q&A. Thank you to all of our attendees for attending and for also sending us the great questions. And we'll work to get all of these answered over the next few days or so. But thank you, Dr. Bond.
I will definitely be happy to answer these questions, either via you, Steve, or write me directly. Yeah, I'm here for questions, even after the webinar.
All right. Well, we look forward to seeing you at ESOT and perhaps WTC as well in the US later this summer.
Great. Thank you for having me. Have a great evening. Bye.